Good afternoon, everyone. I'm going to share with you the evaluation that we conducted in Central America to determine if combination prevention efforts are effective on increasing condom use among sex workers in the region. So to give you a little bit of background, well, we all know that a single intervention will be not sufficient for HIV prevention. So us, as the Pan-American Social Marketing Organization, PASMO, began implementing a program for a combination prevention program with another HIV partners in 2011 in 6 Central American countries. And the program links behavioral, biomedical, and structural services for a range of key populations that include sex workers. This is a USAID program, and as I told you, it's a minimum package of combination prevention that includes behavioral, with the behavior change communication activities and access to water-based lubricants and latex condoms. It also has the biomedical component, which is includes the HIV testing and counseling, and also STIs diagnosis and screening. And with the structural, we have reproductive health services for sex workers. We offer also referrals to support groups for stigma, discrimination, violence, legal support, and a third component is referrals for alcohol and drug treatments. This is offered for so many populations, like people living with HIV, transgender women, men who have sex with men, female sex workers, and another men at risk and Caribbean populations. It's a 5-year program that started in October 2010 and will end in September of 2015. And it's implemented by us, PASMO, as a network partner of PSI, and we have another program partners, and also the collaboration of the Ministry of Health, another NGOs locally, and the private sector. So what did we do? We conducted a midterm evaluation to determine the program effectiveness. We tested associations between the exposure to the program components and HIV risk behaviors, such as consistent condom use with clients, consistent condom use with regular partners, and HIV testing in the last 12 months. We used time-location sampling, recruiting a total of 3,000 and almost 300 sex workers in the 6 countries of Central America. And we recruited female sex workers, fixed and street-based, from 18 to 49 years, residents of the study cities, which were 5 cities per country, with the exception of Panama, where we used 3. And what did we do? We created statistically equivalent groups of exposed and unexposed respondents. We used coercion exact matching, and matching on social economical status, age, length of time working as sex workers, and location. And we used logistic regression to get the average treatment effects for the HIV testing and the condom use. And it's also important to mention that this study was revised by the PSI Ethic Board and by the local committees in each country. So we use coercion exact matching, which is a not very common method to do evaluation. And this method works by exact matching on variables between variables chosen by the user. And they can be redefined to ensure a greater success in finding matched cases. Some descriptive results for the 3 outcomes that we measured. We have that condom use with clients remains high, according to what they report, with the exception of Belize. It's higher than 80% in most of the countries. But condom use with regular partners, it's 60% the highest. It's some countries where it's lower than 30%. And the HIV testing in the last 12 months is between the 65 to even 98%, depending on the country. What did we evaluate? So we evaluated the consistent condom use with any client and what is the correlation with exposure to IPC plus biomedical, and IPC plus biomedical and structural. And we didn't find any impact in the consistent condom use with any client. But when we measured condom use with regular partners, we found that in Costa Rica and Belize, being exposed to IPC gave them more likelihood to be consistent users with regular partners. In Costa Rica and Panama, the exposure of IPC plus biomedical also gave them more likelihood, and the whole package in El Salvador also showed more likelihood of consistent condom use with regular partners. We didn't find also evidence of impact of being exposed to IPC for any of the countries, and we didn't find also impact in Guatemala and Nicaragua. So what was that impact? In El Salvador, the female sex workers that were exposed to the 3 components were 2.3 times more likely to be consistent condom users with regular partners. In Panama, the sex workers exposed to IPC and biomedical were 2.3 times more likely. In Costa Rica, exposed to IPC were 2.7 times more likely, and if we add the biomedical, they were 3.5 times more likely. In Belize, exposure to IPC made them 3.8 times more likely, but we have a wide confidence interval since the sample was very small. Some limitations that are important to mention is that this study uses a post-only design, and we know that this can introduce some recall bias. It's also important to remember that these behaviors that we measure, the outcomes, are self-reported, so also can contain some bias to under or over-report. The CEM methodology also matches only along observed variables and does not account for unobserved ones. And there is a trade-off between the increase in the number of matched pairs and the expense of less exact matching. That is something that CEM contains as part of its limitations. So to conclude, our findings suggest that combination prevention strategies can contribute to condom use with regular partners among female sex workers in Central America. From 6 countries that we tested, we found in 4 countries a difference, especially in condom use with regular partners. And we were discussing a lot about this issue, and condom use with clients is already at a high level, so it's not that easy to show a difference and to prove a change over the time, but with regular partners, we found some interesting results. Multiple interventions and services allow target groups to address deeper factors and influence their behaviors. As we saw in Costa Rica, the more exposure that we add to different components, the likelihood will grow. So this gives us a good indication. And because of that, we recommend that the program should continue offering combination prevention interventions to female sex workers. And we would like to acknowledge to USAID and PEPFAR, which are the ones that have made possible these efforts because of their support, their financial support to our organization and the partnership that we both have. Thank you very much.
Thank you. Do you want to wait there? Thank you very much, Jorge. Are there any questions from anyone? Number 6.
Thank you. Jan Huiblands from Amsterdam. I was happy to hear that social marketing is your frame of reference. I'm curious why factors like working conditions are not being measured because the space to negotiate in your work is an important one for prostitutes, I gather. And I would like to hear your comment on that.
Thank you for your question. So, if I understood well, why we didn't measure working condition as a factor for the, okay. We did. As part of the analysis, we included a lot of factors and control for another factors in our analysis. What we were trying to find out was the association between being exposed and the behavior. And we tried to use another factors, external factors to control for. In our case, the prosecution is not that intense in Central America, with the exception of Belize. That is the only country that has illegal sex worker stated for it.
Maybe I didn't ask the right question. Negotiating, I mean, is something between the client and the prostitute, and the owner of a brothel might be extra pressure to go one way or another way. I mean, there is a difference between girls working in the street or in the brothel, and sometimes it is an advantage because they can walk away and from certain clients that don't want to have a condom, and other girls, or in other countries, it's more nice to work in a brothel because you are safer there, because the owner of the brothel is helping you to keep out the wrong clients.
Okay. Well, in this case, in Central America, the situation is the program interventions always take that into account. And usually when they approach a bar or a brothel, the first contact is with the owner, because they are the ones that allow the intervention. So part of the program is to negotiate that support from the owner. And the owners always contribute, because actually for them it's better to have their female sex workers healthy, and we go there, we give them interventions, we give free condoms, and we offer HIV testing. So for them it's a plus, and they actually support the work that we do. We haven't faced that much rejection in Central America as if we compare to Africa, where owners really own them and are very drastic with relationships. Thank you.
Is there someone at mic 7? Sorry,
yes.
Sorry,
Hi.
It's hard to see from here.
Kylie Tattersall from New South Wales, where sex work is decriminalised. And since that, we've had no recorded case of HIV transmission from sex worker to client. First of all, I'd like to respectfully disrespect with the first speaker's statement regarding a unified response to HIV under criminalisation. I do not think that is possible. As long as sex workers are criminalised, condoms are being destroyed by police, they're being denied access to ARVs and being locked up, we will never address the HIV pandemic. Second of all, I think a really beautiful thing has definitely occurred in this conference, which is the recognition of decriminalisation as the only legislation that will address the HIV pandemic, but most importantly, allow sex workers' rights and safeties to be enhanced and improved. So it's a little bit depressing, to be honest, to be standing in this huge, beautiful plenary and seeing no sex workers on that panel, and also having been part of some amazing sessions that had been relegated to the global village. Not that there's anything wrong with that, but it would have been nice to have some of these spaces taken up with sex workers who have a lot to offer to this conversation. So I guess their statements. My question is my concern around US aid and PEPFAR's funding, who we know have consistently funded abolitionist approach to sex work, rescue centres, and anti-trafficking measures that take away the rights of sex workers. So I'm interested to know, are PEPFAR still doing that? And ethically, as researchers, how you feel about that?
So, do you want to try and answer that? Did you have funding from PEPFAR or USAID, or?
We do, but actually I think I'm not the appropriate person to speak in the name of PEPFAR about funding, so.
Okay. Was that an issue that you faced in terms of the programs you could provide with that funding?
Actually, our funding comes from PEPFAR for female sex workers for the project, so.
Okay, and they weren't promoting, in your case, an abolitionist approach, is that right? They were allowing for HIV prevention?
Yes, actually, of course. Sorry?
Did you sign the pledge? Did you have to sign the anti-prostitution pledge?
So there was the anti-prostitution pledge that PEPFAR were forcing people accepting their funding to sign. Do you know if
I don't know about that.
Okay.
Okay, thank you.
Thank you.